everyone. My name is Kayleen Hill, and I support the Optimizing Healthcare Value Program, or OHVP for short. Before we kick things off, I wanted to give you a little insight regarding our esteemed presenters as well as the organization. Veterans Health Administration is the largest integrated healthcare system in the United States, providing care at 1,293 healthcare facilities, including 171 VA medical centers and 1,112 outpatient sites of care of varying complexity to over 9 million veterans. OHVP, formerly known as the Office of Product Effectiveness, was chartered in 2007 and promotes best practices for safe and optimal patient care and utilization throughout the organization. They perform independent assessments of VHA's healthcare solutions, including technology, programs, processes, and services to ensure they are effective and meet the needs of the organization. Jennifer Ford, the director of OHVP, possesses nearly 2 decades of healthcare experience. Ms. Ford optimizes healthcare investments by producing evidence-based assessments to maximize the intended value for America's largest integrated healthcare system. Jennifer enhances healthcare performance through a whole systems approach and deploys proven methodologies tailored to the healthcare industry to extract and maximize value throughout the healthcare continuum. She has earned her MBA, Project Management Professional PMP designation, and is a nationally certified whole health coach. I'd also like to introduce Chris Dykstra, OHVP's Benefits Realization Program Manager. Chris has more than 12 years of healthcare experience in end-to-end revenue cycle management, clinical and business program management, and evaluating technologies such as practice management systems and electronic health records with a specialized focus in access to care. Through business process redesign and optimization, Mr. Dykstra maximizes the opportunities to gain additional benefits while minimizing risks to patient care and future benefits. Without further ado, I'd like to welcome Jennifer Ford and Chris Dykstra.
Thank you, Kayleen. As Kayleen said, I'm Jennifer Ford. I, along with my colleague, Chris Dykstra, will be presenting to you today. I will go first, and then Chris will come on kind of in the middle, and then I will come back and we'll come back to say farewell. But first, before I jump into the presentation, I think it's important to help everyone understand the 4 pillars of responsibility and accountability the VA has to our national healthcare and why it is so important for us to disseminate these learning objectives to the general public. These 4 pillars are: 1, what most people are aware of, delivering healthcare to our veterans; 2, we are the largest teaching organization to our nation's physicians; and 3, we are a research institution. And finally, 4, as many of you may have seen from the COVID pandemic, we are an emergency response unit for national healthcare. These 4 pillars also enhance our position of being a learning organization as well as becoming a high reliability organization. Why we are here is to optimize learning by disseminating valuable research and information that has benefited our veterans and we hope can benefit the healthcare population overall. My colleague Chris Dykstra and I will walk you through a new model of care that was designed, implemented, and optimized at our Pittsburgh VA healthcare system. The VA realized that our oncology practice could be optimized to include a tele-oncology component. What we learned beyond healthcare delivery was that looking at the care model comprehensively produced a value-added return on investment in several areas. We will describe the level of analysis needed to implement something similar outside of our system. Also, in-person and virtual healthcare delivery are not mutually exclusive. The real value is maximizing and optimizing the integration of the two, producing a hybrid model of oncology to provide the best care at the right place at the right time. Next slide, please. As Kayleen outlined in our intro, you might want to know who is the VA. As I mentioned, we are the 4 pillars: healthcare delivery, teaching research, national emergency response, that positions us as the largest integrated healthcare system. As mentioned, we have over 170 medical facilities that houses most, if not all, healthcare specialties, and over 1,100 outpatient clinics that are fueled by over 360,000 employees serving 9 million veterans. We train over 120,000 resident physicians per year, which is 70% of the US physician population, hence a teaching organization, as well as partner with over 1,800 academic affiliates. A few of our strategic initiatives and focus areas of success are timely access to care. We continue to build high reliability into our organization. We enhance the veteran experience and satisfaction and increase operational efficiencies and effectiveness while gaining lessons learned and building knowledge for more informed decision-making. The tele-oncology scope of practice demonstrates achievement in each of these areas in which we will describe throughout our presentation. Next slide, please. The Pittsburgh VA healthcare system is a microcosm of the VA integrated health system. As you can see, the system is comprised of 2 medical centers in Pittsburgh, known as University Drive, as well as our Hines location, along with 5 connected outpatient clinics. The University of Pittsburgh is also an academic affiliate of the Pittsburgh network. What is challenging to this microcosm is, next slide, please, the catchment area. Pittsburgh is the red circle at the bottom left quadrant area of the map, but the big circle encapsulates all of Pittsburgh's western market that also includes slivers of West Virginia and Ohio markets. Some of these remote sites are over 100 miles away from the hub facility, Pittsburgh, which houses the main and critical specialties. Let's take a look at a very sick cancer patient living in Erie, Pennsylvania, which is 128 miles away from the cancer center in Pittsburgh and a minimum 2-hour drive. In fact, in listening to our patients' concerns and pains, it can be much worse. We had incidences of our patients boarding a bus to travel to Pittsburgh for their infusion and treatment, coming out exhausted and weary, reboarding the bus to go home, a round-trip effort that can take all day, only to have to repeat the process each week until treatment is no longer necessary. Now tell me, how many of you would find that acceptable? Because we listened to the need and change to these experiences, a new model of care to include a hybrid of in-person and virtual oncology was created. Many of us live in metropolitan areas that facilitate efficient and effective access to care and may not realize the significance of this effort. But in fact, Pittsburgh is more representative of the U.S. healthcare population as it pertains to the rural healthcare community, where 1 in 6 Americans live in rural areas, while 66% of them do not have access to oncologists. In fact, 32 million Americans live in counties, rural or otherwise, without oncology services. Given the right analysis and tools, this solution can be modified and help solve the healthcare gap for these populations. Next slide, please. Telemedicine implementation is complex. In fact, the biggest critical success factor for telemedicine is to define in depth your entire process within the category of care that is intended for telemedicine. The reason being is that an analysis of the potential failure points and critical success factors must be identified and simulated for effectiveness. In our case, this initiated a business process reengineering effort that identified all the points of care within the total oncology reach that were necessary to bring into the overall integrated focus. Even though we had all the care disciplines of care navigation, oral treatment, infusion clinics, palliative care, and survivorship clinics, the handoffs and transitions of care were not coordinated or effective from a patient's perspective. VA strives to provide patient-centered care in a highly reliable organization. Therefore, it was necessary to identify the entire flow of care through each and all potential areas a patient may experience. This flow demonstrated the patient's journey versus the provider's specific scope of practice. This realization provided the means and requirements to initiate a tele-oncology practice. For instance, to avoid stage 4 hospice patients ending up in the ICU, a data integration and communication effort was necessary amongst all specialties and providers involved. Moreover, the re-engineering effort created opportunities to maximize our provider scope by having them operate at the top of their license. One of the first steps of analyzing our patient population was to realize that nearly 50% of our cancer patients were being treated by oral medication therapy. The VA has had an incredibly strong clinical pharmacist practice. What this analysis yielded was that we could impanel the patients to the local clinical pharmacist, an easier and economical way to recruit and maintain resources into those remote areas while still being overseen by a remote oncologist. This ability to promote our clinical pharmacists demonstrates benefits of the program by providing improved access to care to patients and job satisfaction by relieving provider burnout and elevating the scope of practice to our pharmacists and nurses. Next slide, please. Now that the process has been identified, the next step was to ensure all necessary provider functions could perform the necessary and safe interventions as defined. As you can see here, this investment encompasses a comprehensive multidisciplinary team model where high reliability in communications, deference to expertise, and integrated transitions of care is paramount to success. Now, Chris Dykstra will walk you through this streamlined model of care and explain the benefits of each component. Chris?
As Jennifer Ford outlined, in order to efficiently utilize and adopt modern technologies like virtual care modalities to provide effective care to our veterans, we first had to define and document the processes, workflows, and measurable inputs and outputs that technologies can and will support. By defining the needs of the veteran, provider, staff, and VHA system, we were able to delineate the functions that virtual care supports within each feature of the care model and maximize the benefits to each of the suppliers and customers. As you can see from the workflow diagram, there are two specific technologies identified. The first virtual technology is CVT, or clinical video telehealth, where the provider at the hub site dials into a video appointment with the veteran and a nurse or tech at the spoke site, and VVC, or VA Video Connect appointments, which has evolved to enable the hub site provider to directly connect with a veteran who is at home through a video encounter. The second virtual technology is an e-consult, or electronic consult, which returns a referral request to the ordering provider with specified guidance on the care plan or appropriate follow-up activities. We will also discuss utilizing telephone encounters in place of video and face-to-face care, as well as innovative care delivery solutions like the USPS. We'll start our journey with cancer navigation, which is a first step in the oncology care pathway and a critical success factor in maximizing efficiencies in care downstream, providing the first opportunity for virtual engagement with the veteran and/or their case through a telephone encounter. Next slide, please. All new veteran cases are referred to oncology through a referral order in the electronic health record, known as in the VA as a consult order. To ensure a smooth transition into the oncology service, the consult order template was redesigned to simplify the requirements for prerequisite workups, including a separate consult specifically for the cancer navigators to proactively identify, collect, and scan any outside medical records associated with the case into the electronic health record for the oncology provider's review. By coordinating with the triaging oncology providers through the EHR and in person, and ensuring cases referred to the specialty are complete with all relevant records, pathologies, images, and labs, Navigators expedite the ability for the providers to evaluate each case and determine if the case is ready to be accepted. In the event that the case is not appropriate for the service, an electronic consult or e-consult was then developed to return the consult order with recommendations and guidance on treatment and follow-up. If the veteran's case is accepted by the oncology care team, the Navigators provide a warm introduction to the service through a telephone encounter, informing the veteran of expectations for their appointment and screening for necessary care coordination activities, providing a welcoming environment to managing their care. Next slide, please. Benefits of Cancer Navigators include technology-driven benefits achieved through the development and optimization of the consult templates to reduce specialty care revisits and additional travel times for veterans to complete necessary pre-work while expediting the time to confirm and initiate treatment. It also captures workload in the electronic health record for care coordination activities. E-consults promote closed-looped communication pathways between care teams and establish the VA as a learning organization, providing a platform to continually improve and educate primary care or other referring providers on effective treatment regimens and appropriate care settings for different cancer cases. Telephone encounters and appointments establish single points of contact to improve patient satisfaction and reduce anxiety related to diagnosis and treatment by ensuring veterans are informed of their options prior to their first appointment. Next slide, please. Once the veteran has been accepted into the service, they complete their first appointment with their oncologist at the Pittsburgh hub site. However, depending on the severity of the diagnosis and location of the veteran, a VVC or CVT appointment may be provided to reduce travel burdens and expedite the initiation of treatment. The next step is for the oncologist to develop the treatment plan, which has been standardized as a note type in the EHR, providing all team members across all sites with a uniform view of the designated treatment and complete care plan. Today, we're focusing on outpatient care, including both oral and IV anti-cancer therapies. The first treatment type we'll discuss is oral anti-cancer therapy, which now accounts for nearly half of all treatments provided at Pittsburgh, almost entirely delivered through virtual care modalities. Next slide, please. The oral anti-cancer therapy clinic is run by a PharmD specialized and board certified in oncology care who communicates and provides care to veterans through CVT and VVC virtual care modalities. The PharmD has full practice of authority to follow up with and engage veterans remotely, and the CVT and VVC modalities allow them to screen for adverse reactions or side effects for treatments proactively and evaluate treatment compliance in real time while the veteran is at home or the closest facility to them. Since all veterans treated via oral anti-cancer therapies at Pittsburgh are impaneled to the PharmD, the oncologists are able to focus their time in the physical or virtual clinic on new cases, developing and updating treatment plans, and following up on veterans that are not able or not responding well to their treatments. When necessary, the PharmD leverages the EHR, Microsoft Teams, and telephone encounters to communicate with the oncology care team across the spoke sites. They do so by signing off on it or recommending adjustments to the dosing or treatment plan as an addendum to the standardized treatment plan note type, which is then reviewed and updated by the oncologist. Driving communications between care teams through a single standardized note type in the EHR ensures that all providers across the VA system have expedient and clear insight to the veteran's case to provide effective care. The PharmD also reviews, procures, and mails oral anti-cancer therapy medications directly to the veteran or writes an order for the veteran to have their prescription filled at the local VA pharmacy. However, nearly all additional rounds of oral anti-cancer therapies are mailed directly to the veteran. Believe it or not, even though it was officially established over 50 years ago with roots tracing back to over 246 years, the United States Postal Service is now providing the means to deliver anti-cancer treatments directly to the veteran's door. Next slide, please. Providing virtual consultations, treatments, and follow-ups to the veteran through CVT, VVC, and phone encounters improves veteran quality of life by minimizing travel requirements, dispensing medications at the veteran's local facility, and administering therapies at home. It reduces toxicities associated with traditional forms of anti-cancer therapies, including IV chemotherapy, and extends veteran lifespan, transitioning conditions from an acute to a chronic state. Can you believe that some cancer diagnoses that used to be a death sentence are now managed with a daily, weekly, or monthly pill? It also mitigates negative physical and psychological side effects from treatments by providing the care that veterans deserve in the comfort of their own home while enhancing medication compliance and reducing costs of the system. The extra time gained back to the oncologists in clinic and research provides the time and resources to develop innovative care models like this, and also provides us the opportunity to communicate the information directly to you. Next slide, please. The next treatment option we will discuss is the virtual cancer care clinic, the centerpiece of the integrated care model, which delivers a hybrid CVT, VVC, telephone, and face-to-face care experience to veterans by providing remote IV chemotherapy administrations at the veteran's home spoke site. Next slide, please. The oncologists in Pittsburgh who establish care with the veteran during their first in-person or virtual consultation appointment will screen the veteran through a CVT encounter prior to the veteran's chemotherapy administration at the hub site, reviewing the labs, images, and other prerequisite criteria provided by the oncology nurse team at the spoke site. Now imagine that you're a cancer patient at your local facility and the people in the audience around you are your local oncology RN care team. I'm your oncologist and you'd be interacting directly with me through our television screen. Even though the oncologist, which is me, is hundreds of miles away or thousands in this circumstance, I can still effectively oversee the preparation, screening, and administration of your treatment through these types of virtual modalities. Once you've been worked up with the nursing team, determined to be appropriate for treatment, and you provide your consent to receive the treatment, I would sign off on the treatment plan and alert the pharmacist to compound the chemotherapy through the electronic health record. The nursing team would then administer the IV chemotherapy directly to you at the site. To ensure a safe environment, since I, the oncologist, am not physically there with you, and in the event that you have an adverse reaction or do not respond well to the treatment, there's a rapid response team on site prepared to stabilize you and ensure expedient care to mitigate potential risks to your health. Regular follow-up is then provided by me virtually to you while you're at your home through VVC or at the spoke clinic site through a CVT encounter with a nurse or tech present, particularly when scans, labs, or other diagnostics are required to actively monitor your condition. Next slide, please. Benefits of virtual cancer care clinic associated with the delivery of remote IV chemotherapy treatments through a hybrid virtual and in-person care model include reducing financial burden in health system travel programs due to distance, time, and cost, enhancing your experience and satisfaction by delivering care closer to your home, improving your multidisciplinary access to safe cancer care in rural areas by engaging you through treatment, surveillance, and follow-up care services via virtual care modalities. And this also includes traveling veterans and snowbirds who are not conducive to be treated within a single geographic facility location. It creates new specialty healthcare specific jobs in rural areas by specializing oncology RNs, CRNPs, pharmacists, and PharmDs. It also ensures you're maintaining appropriate treatment intervals with potential to reduce treatment costs and waste by compounding therapies after you have been screened for appropriateness through your physical examination, blood work, and labs prior to administration. Next slide, please. A supplemental but necessary feature in providing oncology care through inpatient and outpatient environments is the early integration of palliative care services, most often leveraged through VVC or CVT encounters. Although hospice and pain management are some of the primary functions, a large service in oncology palliative care is symptom management from the side effects of treatment. And with a large geographic reach for oncology care services, the virtual care modalities are vital to the success of this program. Next slide, please. The palliative care team is located at the Pittsburgh hub site and mostly provides care through VVC and CVT to veterans treated at both the hub and spoke sites. Care is also often delivered in conjunction with the veteran's regular follow-up visit with their oncologist, maximizing appointment times and convenience for the veteran. The veterans that benefit from the service most are also the most appropriate candidates for virtual care. Veterans with advanced stages of cancer and the most pain with the highest toxicities and least able to travel to a medical center with any level of comfort. Next slide, please. One of the most important benefits to the organization and the veteran is that palliative care reduced costs by initiating and integrating care and hospice services early, while ensuring the goals of the veteran's care are being met based on the preferences in their advanced directives. This reduces ICU, emergency room, and inpatient hospital admissions, as well as chemotherapy treatments closer to the end of life. Next slide, please. The final feature of the care model is the survivorship clinic. Next slide. The survivorship clinic is also located at the Pittsburgh hub site and primarily delivers care through VVC and CVT encounters to veterans at both the hub and spoke sites. The clinic provides a one-stop shop to the veteran and their family for a summary of all care and treatment activities, post-treatment support resources, and post-treatment expectations. Next slide, please. Benefits of Survivorship Clinic include improving patient, family, and caregiver satisfaction by keeping the entire care team, including the veteran and their family, informed of the veteran's status and condition through a co-signed summary note and surveillance plan documenting the care life cycle from diagnosis to the completion of treatment, including follow-up care intervals. I'm now going to transition back to Jennifer Ford for the overarching impacts of the care model.
Thanks, Chris. And as you all might have guessed, we could spend sequestered days analyzing the process and benefits at each step of the way. However, we wanted to help healthcare professionals understand the level of effort, scope of the effort, and most importantly, that it can be done very effectively and yield tremendous benefits to your patients and your healthcare organization. In fact, on a personal note, I would have loved to be a part of the VA system back when I was diagnosed with cancer. I'm perfectly fine now, but back then I was scared, didn't know where this was heading, and didn't have the same level of care and coordination as our nation's veterans do. I had to navigate the system myself, and no one else really cared about me as a survivor like we do and keep tabs on our veterans' progress throughout their lifetime. As a cancer survivor, kudos to the VA for such a center of excellence. So just to reiterate some of the overarching impacts we realize at the VA. 1, access to care. You can choose a hybrid model to fit your needs without sacrificing quality and safety. 2, you still can see and hear your provider. You still get a personal touch. 3, the model truly puts our veterans in the center with all disciplines revolving around their needs. 4, we build trust by listening to our patients' experiences in which to improve. 5, it facilitates faster and reliable clinical decision-making. 6, demonstrates value and return on investment. 7, it integrates a team-based approach to maximize productivity and satisfaction. And 8, it reaches rural areas so to expand the practice to patients needing critical care. Next slide, please. And the practice is growing in leaps and bounds as a testament to its success. The green dots are showing the growth of the program from inception to maturity throughout the system. If you look closely, there's significant growth in the Altoona and Erie sites, both remote, due to the deployment and demand of virtual care clinics. These optimized business processes are being scaled and analyzed at our national deployment teams so our VA system can maximize the true potential and benefits of this tremendous technology venture. Thank you for attending our presentation. I welcome Chris back on screen, and we both would like to wish you farewell and have a great conference.